Socially, he smoked briefly in his high school years, but he has not smoked in years. He's currently divorced. He has 3 children from his previous marriage. His wife left him 3 years ago. Recently started dating, and his current girlfriend suggested that he needs to get checked out before things got serious. And and the question is, what does things get serious mean? I don't know, but it's up to you guys to figure out what he wants by things getting serious. And we were able to get his records from 10 years ago, and his cholesterol, his A1C, his liver and kidney function were all fine. So this looks like a pretty good guy. He's seen his doctor in the past, but he's not seen him for a couple of years. He has 3 kids, so let's give and take. He's not seen his doctor for close to 10 years. And how are you going to approach this young gentleman? And Koba, do you want to, what are you going to do for this young gentleman?
Sorry, I do apologize. Can I ask a question? Where
Yes.
does this person live? Is the person in the US or is in Ghana?
Good question. I'll put this guy in the US for now. This guy is in the US.
Okay, thanks.
For now, he's probably going to relocate, right?
But that's a good question. This guy is in the US.
He came back and pretend to see Koba.
Hello, so before you go on, sorry, I sent a message. I think people are struggling to get on.
Oh, I see.
Yeah, I think so.
Is it for the people who are trying to get on? Is it because if it's the link is not working, but the link should work, but you need to use there is a code, a passcode. Sometimes they request the passcode. It's MEN 2020, MEN 2020. So if it's requesting for a passcode, that's what it is.
So the passcode.
You need a passcode when I click the link.
Yeah, if you click the link in the
Flyer.
the flyer, it takes you directly. You don't need a passcode.
What they have here is this meeting ID is not valid. Please check and try again. That's 1 or 2 tests that have been sent to me. Thank you.
So
the passcode is MEN
2020. And they don't need to put in the meeting ID. I'll Matthew, let me send you the link so that you can send it to them.
Thank you very much.
Okay. So I stopped sharing so that I can send Matthew the link.
Koba, can you
Can you talk now?
Just start off and then I'll hand over to. So now I'm going to start off with the history. So I'm going to delve into, what he. First, I think whatever he had done 10 years ago, everything appeared normal, right? Yes, so my history is going to look at his socials. Is he taking any alcohol? Is he smoking? Is he doing, is he coming with a wife? Let me get that one first. Is he in there with his new wife?
No, he didn't come with a wife. He came alone.
He came alone, okay.
And so, it's actually not it's a divorce. He's currently dating a new girl.
Okay. Then I'm going to go system by system because it looks like it's 10 years ago. Everything I have is way back as 10 years. So I need to look at any symptoms that he may have, right from the head to toe. So I'm checking whether he has headaches, whether he has any signs of chest pain, any discomfort, any heart racing, what his breathing is like. I'm going to come all the way down to his GI, so what his bowel habits are like, going down what his urine is like. Is he urinating more than he should? In fact, that would not be a way to go. But how often is he waking up at night to urinate? Is he training? And then if there are any other muscle pains, back pains, I'm going to have all that and then dovetail into his social. Now the aim here is to get him as comfortable as possible before I get into the social, So the social will take me to alcohol, smoking, any hard drugs, which is pretty common now. And then we would go down to sexual history. One of the quite things that was stated was that before things get serious, it could be before things get serious, as in before they get married, or before certain a condition that he has gets worse, right? So normally, when first time, I wouldn't normally go straight into sexual history, as in whether you have any problems with erections and stuff like that. But it all depends on the rapport that we establish. And if it's going smoothly, I'll probably use this opportunity, especially since there's a woman involved, to go and find out, what that is like. Whether he's getting good erections, is he able to sustain it and penetrate. Then my next point would be requesting the test. I'm assuming that by the time he comes to me, we've done the basic things like his blood pressure, etc., etc. But at this point, I'm going to run as many tests as possible because it's going to act as a baseline. Whatever I had is 10 years ago, not very helpful to me. So, okay, let me just run through what some of the things I'll probably do. I'm going to probably go ask for a full blood count, C-reactive protein. I like that because it sets me off as to look for other things that may have gone wrong. I'm going to look at his kidney function, his liver. It's 10 years, so I'll put in a thyroid. We'll look at his lipid profile, look at his blood sugar. Normally, we would do a random fasting, HbA1c, whichever is appropriate at the time, we would do that. What else am I going to put in there? I will look at the urine, which is extremely important here because it can lead us to many other things. I think I skipped the fact that his examination would be from head to toe because he hasn't done one in a long time. Normally, what we do in a primary care setting is nothing really extra, but I would obviously look out for signs of, anemia, listen to his lungs, his heart, examine his abdomen, and then, at this point, I'm probably not going to do it. I see one of the things that's a DR. I'm not going to start touching his prostate at this point. If I wanted to, or I think it's a high risk person, I'm probably going to ask for the PSA first before he'll come in later. One, because the DRE is probably even going to push the PSA up anyway. At 48 and a Ghanaian, asking for PSA at this point would depend a lot on his family history. A few years ago, I would catch every 40-year-old and ask for a PSA. I know I spoke to a few of the urologists and they're like, there's too much anxiety and stress, and especially based on what the outcomes are in most cases, it's probably not that necessary to start so early. Now, I would do a 40 to 45 if you have a very bad family history. So if you have both maternal and paternal sides with histories of prostate cancer, then I'll go ahead. But at 48, if he has no knowledge of CA prostate in his family, I'm probably going to skip and let him come in at 50 or so when I'm doing his colonoscopy. What else would I put in there? Did I say I was screening for sexually transmitted infections?
No, you didn't say that.
Okay, so I'm going to do that because especially when it comes into what do you call it, probably going to have more children. And I'll probably screen for do HB electrophoresis since he's Ghanaian. Yeah, and for what it takes, I'll need his blood group on file. So I'll put that.
Yeah, so the HB electrophoresis, a lot of times we ignore it, and because we think, oh, it would have been diagnosed long ago. But yes, this guy is somebody who is going to get married. It's a good idea to do it. It may be AS and doesn't know. So it's really important that we do that. One other thing, would you do STD screening? Did you say STD screening on this guy? Who is going to do STD screening?
Yeah.
So can you reshare your screen?
Okay.
And can you guys break it down like with STD and CA and stuff? Can you break it down so that people who are not medics can understand?
Okay, thank you. It says I'm sharing my screen. It looks like I may be sharing the wrong screen.
Zoom troubles. It takes a while to get used to.
Yeah, I can see your screen. Just go to presentation.
I'm going to change it and share the right one. Is it sharing? Is it coming on now?
It will come soon. It says you are sharing.
It is. I can see it.
Okay. All right. You know, so that's the case. And then, so the other thing that Koba has talked about, where most of the stuff, is there anything else somebody would like to do other than what Koba has already mentioned?
I think we wanted to do something on STIs, right? I don't know.
Yeah, and I think it's a good candidate for STI.
So that's in your territory.
What are you going to do? What venereal disease are we going to check on this guy?
Lawrence, you're smiling. Why don't you come up?
Oh,
Yes.
I don't do STD now, but I've done a sexual health clinic before. So the group was a bit different. It was more people who indulged in higher risk sexual behavior. But we do chlamydia, HIV, obviously. And there's the usual stuff if he's not had it done before, like I said. Has he had a hepatitis screen? He may not have had one done before. So chlamydia, gonorrhea, syphilis, HIV, obviously, and then hepatitis. And those are the ones that I would think of doing.
And hepatitis is really very important, especially for the Ghanaian community. I think the last time I checked, hepatitis B prevalence in Ghana is about 6%. And most people actually is perinatal transmission and they wouldn't know about it. They most probably got it from their parents. And hepatitis C is a little bit on the lower side, but it's also really very, I'll say it's a generalized endemic in Ghana, not usually IVD use. In the US, yes, I would always recommend doing them on anybody, especially if you are working in an African a clinic that sees a lot of people from West Africa. You always, it's a good idea to do it because for hepatitis B, maybe a chance to give them the vaccine. So I'll move on to the next case, and I'm going to read quickly. And this one is a 66-year-old Nigerian man. This guy is living in Ghana now. Nigerian man was referred to your clinic by his PCP with a prostate-specific antigen level of 8 nanograms per mil. It's seen in a routine evaluation. He has no other medical issues. I made a mistake, sorry. He has no other medical issues. Social history, drinks beers daily, non-smoker, married with 4 children. Oldest is about 39 years and runs a Chinese restaurant on the corner of the street. His physical exam was normal and the dictal rectal exam revealed a slightly enlarged prostate. So this guy already had his PSA done and he was saying to this guy's, I'm going to give this guy to Matthew Che, and his hemoglobin was 15 grams, hematocrit was 43, WBC count was fine, and his platelets were also fine. His blood urea and nitrogen 15, creatinine of 1, and the normal alkaline phosphate and liver function test. His chest X-ray, bone scan, and CT were negative. And just look at the PSA of 11, that's a mistake. You did the ultrasound guided prostate biopsy, revealed the Gleason score 6-7, 4+3 prostate cancer. Histology showed adenocarcinoma in 6 of 12 specimens. So Matthew, is it common for you to see a lot of patients like, is it a typical patient that is referred to you, or is it typical for you to see patients like this being referred to your clinic?
Okay, good. So this is a patient or a client who is 66-year-old. Just like the 48 years old that we discussed, normally for us, above 45, prostate cancer is a major issue for us. The PSA is the prostate-specific antigen, which is the lab test that we do. Luckily for us in Ghana, most laboratories can do it. Initially, there were a lot of disparities between the figures we get. But in current, I realize that there's a lot more of aggregation, or things are coming together. So we are willing to work with the laboratory results that we get. Good. So the PSA, the normal range is supposed to be between 0 and 4. So when you do this blood test and it's 8, then it is a bit high. There are a few things you must take note. The first thing is that as one age, the PSA tends to go up because the PSA, we know, is produced by the prostate. And as we get older, the prostate gets bigger. And so the PSA can go up. So for instance, if somebody is 80 years old and the PSA is 8, we may not be that much worried if there are no symptoms. But for 66, a PSA of 8, we will consider it a bit high, that needs to be taken care of. It's a common occurrence now, especially in the urban area, because people go and do the checkups and then this test are done. So for this patient of PSA of 8, we'll do a dictal rectal examination, or we'll put the hand in the anus to check on the prostate. The first one, it was said that, when we examine the rectum, maybe we may put the PSA up. The reality is that if you do a gentle DRE, normally the PSA doesn't change much. But if you should do what we call a massage, then the PSA can go up. So for this patient, doing the rectal examination is a good idea, which had been done. And it was followed up with the biopsy. Now, the biopsy means that we put a probe in the anus and pick on the prostate to the lab for the pathologist to look at. We've got a pathologist on the line, so I'm sure he'll talk much about it. The importance of this study is to find out whether first there's a cancer in the first place. So from this scenario, we can see that the cancer was confirmed as there were prostate cancer there. The next important question is that, is this cancer likely to kill this person if we should leave the person alone? And that is where the Gleason score comes. So the Gleason score just tries to tell us whether this is a cancer that is risky or something we can dilly-dally about. So generally, we have got 3 categories. We have got what we call a good prostate cancer if the Gleason score is 6 or less. An intermediate, midway if it is 7. And then if it is 8 to 10, then we say this is probably likely to be a bad prostate cancer. So for this patient, with a PSA of 7, we can say that his prostate cancer is intermediate. And almost all countries and all urologists and pathologists will advise that this cancer needs to be treated. Because if we don't treat, the chances that about 80 or less about 30% of them may be dead in the next 5-10 years. So this is a cancer that we need to treat. So this is a 6-year-old, has had a good assessment. The PSA is 8. Rectal examination likely to be abnormal, and a Gleason score of 7, he needs to be treated. And I think that so far he has had a good assessment. Thank you.
So there's a question which I want us to answer before we go on. Okay. So this I think is mainly for Koba. So the question is, as a non-medic, this seems to be a very deep dive analysis of the patient. Would you do this investigation for every patient, every in capitals? And then do you have the time? And then how about a more holistic approach, asking the patient questions? And then other signs may show up as fine, but then the actual cause may show other symptoms. I'm not sure what that means. Maybe he's caught something from the partner. So it's a kind of a whole lot of questions in one, but if you can address that before we move.
And I think this question is related to both the first and the second cases. That's the impression I get. So,
okay. So normally, when I see a client like this, so let's assume he came in like the 48-year-old came, and as part of the test, we found a PSA of this sort. Now, when a client comes in, what we are looking at is, if I'm going to check for PSA, are all the other organs fine? What is your general health like? So most of them are likely to get everything in here. So I'm going to do a full blood count. I'm going to do a BU creatinine. I'll do the liver function, but I would normally not do the abdominal CT. I wouldn't do the bone scan, the chest X-ray, and the abdominal CT. Normally, it's when I have referred this client to the urologist that they tend to get the other ones. Sometimes we actually call the urologist. I keep bothering them a lot, and I'm sure other doctors do too. And then we discuss the case, and then they will request that, okay, before you send him to me, maybe do the abdominal CT, do the chest X-ray, do ABC. Bone scan is quite difficult to get done here. It takes forever. So many times we bypass that and do things like maybe an MRI with a contrast or something of the sort. But by and large, I think he will get almost everything before he leaves me to the urologist. That's if I go to him first.
Can I make a comment, please?
Yes.
I think probably for those who are not medics, these scans are being done to look for whether this guy has got prostate cancer, which has spread. So we are preempting the possibility that he may have prostate cancer, which has spread. That's why we are looking for other things, doing a chest X-ray and a bone scan, and this CT of his tummy. So the thing is, you're thinking, in case he's got prostate cancer even before you do your biopsies, is there evidence of cancer elsewhere, which might show up in his X-ray as lumps in his chest from spread of cancer, on his bone scan as spread to the bone, or lymph nodes and stuff in his tummy? So you're thinking there's a 66-year-old man with a high PSA. He may have prostate cancer, so you're trying to not go a bit ahead of yourself to save time in this assessment before you even do the biopsy. So that's why some of these things may be done to prevent some of these things. Would the other people agree with that?
I would agree, but I do have a question though, and it goes to Matthew. Matthew, what type of patient? I know a lot of times in prostate cancer, there's this option that they call watchful waiting, and if I do remember, Dr. Yeboah was very, very good on, that you know that this patient may need surgery, but you don't want to do it now. Which type of patient would you do watchful waiting for? Is this guy a candidate? And what about him makes him a candidate or does not make him a candidate for watchful waiting?
Okay, so this is the patient with prostate cancer. So we decide that probably needs to be treated. Needs to be treated means that if you don't do anything about it, it's likely to kill him or give him some complications later. So generally, there are about 3 factors we take into consideration. The first one is the blood test, the PSA that we said.
Okay.
Based on research, we decide that your PSA is less than 10 or more than 10. If your PSA is less than 10 on its own merit, then you can be watched. Okay. So this patient who is 66-year-old with a PSA of 8, on that score, he can be watched.
Okay.
The next thing we look at is the Gleason score. If your Gleason score is 6 or less, that is the good type, then on its own merit, you can't be watched. This patient, the Gleason score is 7, because it's up to 10. So 7, 8, 9, and 10, you can't watch them. The prostate cancer is likely to kill them. Then the third component is what you find when you examine them by the rectal examination or by any imaging like the MRI, CT scan. If it shows that the cancer is occupying virtually the whole of the prostate or it has spread out to the prostate, then that patient, you can't watch that patient. So we look at all of these parameters, either individually or in combination, and take a decision. But I must be quick to add that when you look at these parameters, for the whites or the Asian, it works fine. For us Africans, it's a dangerous thing. Many studies have realized that first, when you do a biopsy and you say this African has got a Gleason score of 6, in about 30% of cases, it is not true. As we rightly said, when you go and remove the prostate and they analyze the whole thing, there's an upgrade. They will find a 7 or 8 or 9 or 10. So your judgment on the biopsy of being 6, you are 30% chances that you are going to get it wrong. But of course, the active surveillance means that you are going to watch this patient. You are not going to get the person out of your sight. 6 months or every year, you do a PSA. If the PSA should move and cross the 10, you are going to bring him to that category. Sometimes you have to repeat the biopsy every year or 2 years. If you do the biopsy and the Gleason moves from 6 to 7, 8, or 9, you bring him to treatment. Or you do the rectal examination again, or the MRI or CT scan. If it has moved outside the prostate, they bring them to treatment. But in all of this course, the Africans tend to do badly. In fact, most studies have realized that if you put people on the active surveillance, I'm not treating you, I'm watching you. About 30% of Caucasians and other races, along the line, you may have to treat them. A year, 2 years, or 5 years, you have to treat them. But the African is about 50%. Okay. You have to treat them. In fact, the latest research says that about 60% chances that if you put an African on active surveillance within 5 years, you have to change your mind and treat them. So African as a race makes this, difficult. And the last component is that we said that it shouldn't get you out of your sight. The average African man will be out of it. Will disappear. The next time he comes, he's in a wheelchair or
Eric, do you have anything to add to that?
Exactly. Or you can't really.
When Matthew, I concur with everything Matthew said. So let me just re-emphasize just what Martin said. So this guy is so let's take a patient whose PSA is less than 10, which is good. You can do active surveillance. His initial Gleason from the 12 biopsies is 3+3, which is 6. Okay, so it means you can do active surveillance. Your digital rectal examination, your CT scan, in the US, we'll do a PET scan, but in Ghana, you do a bone scan. So all your scan shows that this cancer is in a small part of the gland, because the pathology report also helps us. So for example, even if it's 3+3 and the 12 biopsies, maybe 9 out of the 12 has the 3+3, the volume of disease is important. But let's assume there is a PSA less than 10, it's 3+3 equals 6, which is the Gleason score. And out of the 12 biopsies, let's say only 2 out of the 12 is positive. So it's a low volume disease. And then the digital rectal examination and all those scans are negative. This hasn't spread. As Matthew said, the studies that have been done, if it was a Caucasian, and you decide that because it has all the 3 good things, less than 10, Gleason scores 6 or less, 6 essentially, because our pathology report doesn't show Gleason scores less than 6, okay? And then he also doesn't, the disease is not taking the whole gland, it hasn't spread. Only 30% of the Caucasian in the US, at least most of the data, over a 5-year period of active surveillance, you change your mind and treat. But for the African Americans, it's more like 50 to 60%. Okay, even in the US, where you would say that, oh, you have an address, if you are the PCP and the patient is not coming back, or you are the urologist, you can call and send letters. In the case of Ghana, I'm sure it will be very challenging for Matthew. So if you have a 66-year-old with PSA less than 10, Gleason score 6, hasn't spread, it has to be a discussion with the patient. You have to consider the patient's social environment. Is this patient somebody who will be seeing you every year for you to check the PSA, okay, and do another biopsy? You see, the active surveillance means you still have to repeat these 3 things at periodic interval to be sure that the PSA is less than 10. The Gleason hasn't increased from 6 to anything higher, and you have to be in the digital rectal examination. So the active surveillance is challenging because of this reason. And as Matthew also indicated, those African Americans who you can do active surveillance, meaning that their PSA is less than 10, Gleason is 6, the disease hasn't spread beyond the gland because of clinical examination and imaging. If they elect to be treated at the time of the 6, up to almost about 60%, the prostatectomy leads to an upgrade. So you end up finding a 7 or 8 in the gland, So then it becomes, so this was a good thing that we didn't do active surveillance and we treated. So it becomes a more personal decision. Though we say Gleason 6, PSA less than 10, and it hasn't spread beyond the gland or it's not taking the whole gland, you can do active surveillance. A lot of African Americans are not doing active surveillance, even with those parameters, because of these reasons.
Okay, Henry, I have a question. So have you unmuted me? Okay.
No, we can hear you. Talk.
Okay. So I think we are losing the audience, right? Can we step back a bit? Matthew, if we can start off with what men should expect, the early signs and symptoms of, prostate cancer, maybe group it with just regular enlargement, the medium term, can we sort of break that down so people are on the lookout and they know what to tell their GPs when they come?
Thank you very much. I think that if for this presentation, the advice is, the screening. When we started the initial discussions, we said that in most jurisdictions, like the America and the Europe, they will say that don't just, in other words, it's not the doctor's responsibility to screen every man that comes to them. So because you have come to me, well, man, do PSA. No. But it should be a shared responsibility. So you discuss with them that, okay, you are 45 now. You are an African, you are a Nigerian, or you have got a family history of prostate cancer. or you have smoked before, these are some of the risk factors for developing prostate cancer. So I think we should check your PSA to see what it is like. So when we do the PSA, it means that at this point in time, you have no complaint at all. And that is useful. Because when we're talking about the fact that a dangerous prostate is a prostate that is giving you symptoms, it has grown big, it's giving you constipation, it is making the urine not be able to flow, there's blood in the urine, there's back pain. These are bad prostates. So for our purposes of staying alive as men and catching up with the women, I think that the screening is important based on your circumstances. But I would say that if you're an African, I think your circumstances is already predetermined. That if you're an African, I think from 45 years, it's good that you make the check. At least you have what the baseline is. So the symptoms you talk about, like difficulty passing urine, blood in the urine, waking up several times in the night to pass urine, or even getting poor erections, or getting constipation or blood in the urine, they are bad signs. They tell us that when we do the DRE or we do the MRI or CT scan, it's likely to have moved outside the prostate, or it's covering a lot more of the prostate gland, and so we need to treat it. So on this audience, we will say that let's take opportunity to do the screening. 45, at least 50 years is a good idea. We are targeting the 50-year group. At this age, at least you should have done the PSA. The good thing about our race is that when we checked on a prostate that is just big and it's not a cancer, the mean PSA was about 8. So really, there are a lot of people with PSAs about 8, 10, and there's no cancer at all. In fact, a study that we did in the mid of 2000, we realized that if you are a Ghanaian, an African, and your PSA is between 4 and 10, the category we're talking about as good cancer, the chances that if you do a biopsy, we find a cancer is just about 20% or 21% specifically. If you're, in other words, 80% of them, there's no cancer at all. So for instance, for this man who is 66-year-old and his PSA is 8, there was an 80% chance that we will find it as benign in an African. Now, if your PSA is between 10 and 20, the chances move to about 33%. There's a 1 in 3. So if your PSA is 15, there's a 1 in 3 chance that you find a cancer. 1, you find a cancer. 2, you will not find any cancer at all. And if it's more than 20, then that moves to about 45, 50%. But if your PSA is more than 100, the last time it was almost 99% chance. So this is how we analyze it. So if your PSA is less than 10, the DRE is normal. Sometimes we just even keep an eye on you and say that go and come back next year and we'll do another check on you to see how the PSA is going up. If the PSA is rising too quickly for us, more than 0.75 or we say 1 unit per year, then we are concerned. So this is how we deal with people before we jump to the biopsy and then the way forward.
I'd like to ask, and this goes to urologists and also the pathologists in the panel. Why do Black men develop prostate cancers earlier in life and are more likely to have advanced disease at time of diagnosis? What do we know about it? Why? If we don't know also, we can say we don't know, but why? Why do you think? You can also give us a theory. Are there any reasons why?
Okay, so I'm gonna start asking, why do Blacks develop prostate cancer earlier and are more likely to have advanced disease? So,
do you want to share your screen? Do you have anything to share?
I don't have anything on the screen. I'll just say so. Most of the studies, most of what I'm going to report are studies in the US, but there are also some studies in the African population. And in the US, the African American population is a heterogeneous population. African Americans from the Caribbean and African Americans from Africa. But the data suggests that prostate cancer, so non-Hispanic Black men in the US are more likely to develop prostate cancer. So the incidence of prostate cancer is higher in African Americans than Caucasians, or what we say in the US, non-Hispanic Black Americans have the highest incidence, followed by non-Hispanic whites or Caucasians, then followed by Hispanics. The lowest incidence is Asians. So the 4 major racial groups, African Americans have the highest incidence, followed by Caucasians, followed by Hispanics, and then followed by Asian. So for example, the lifetime incidence, that's what makes it easier. You expect that 1 in 4 African-American men will develop prostate cancer in the United States. That's the US data, compared to 1 in 45 for the white population. Okay, so the incidence is higher. It's about twice as more likely to be diagnosed. Now, the reasons are, there are genetic factors to that. Okay, there's been a lot of publications in the past that most of it is pointing to alternate splicing. So more of post-transcription. This is a little detailed for me, but it's more of how the mRNA is handled after it's been transcribed. So that's where most of the difference. Actually, there are companies now that are looking at developing drug candidates, for what we will say anti-spliceosome drugs to help in this direction. So there's a genetic component, but there is also a non-genetic component. Okay, what in the US we generally call the social determinants. Okay, so apart from the fact that the incidence is higher, the mortality too. So if an African American is diagnosed at the same time, at the same age as a Hispanic, with the same Gleason score, I mean, they can have the same PSA level at the time of diagnosis. They can have the same Gleason score at the time of diagnosis. They do poorer. Their prognosis is poorer. Now, one of the major reasons is because at the time of diagnosis, the Gleason score tends to be higher. Even at the same PSA level, the Gleason score tends to be higher in the African Americans than the Caucasians. Okay? But even in the situations where the Gleason score is the same, the prognosis is poorer in African Americans. And that is more related to access to insurance, habits, a lot of African American men don't go to their physicians regularly, so those are more of the social factors, but there are biologic reasons why African Americans are twice more likely during their lifetime to be diagnosed with prostate cancer. That part, sort of the biology, we can't do much of. What we can do a lot about is if an African American and a Caucasian are all diagnosed the same Gleason score at the time of diagnosis, the same PSA level, most of the efforts are to make sure that they all have similar outcomes, and that takes us to the issue of, so the treatment of African Americans with prostate cancer is a little more aggressive in the United States, just like Matthew said. I expect people in Ghana to be a little more aggressive in treating Ghanaians with prostate cancer than what the literature would generally say for the Caucasian population.
Okay, so there are a couple of questions. Let me bring them up and then so you can continue. Sure. So the first one says, are there any receptor markers for prostate cancer like there are for breast cancer to stratify risk and guide prognosis? So that's one. The second one, somebody's saying he urinates 3 to 4 times during the night. Is that a problem? And then let me just add the third one, and then you guys can answer. It says, while doing the active surveillance on a patient who already has developed cancer, is it not possible that by the time a year when this client has to do the routine biopsy, the cancer might have spread to other parts of the body? And the second one is, can we determine how fast or slow the cancer cells grow?
Okay, so I'll come in here. Good. So first there was a question as to when we do the biopsy, that is put the ultrasound in the anus and pick the prostate, how many calls do we normally, would take? In Ghana and like anywhere else, you have found out that 12 is the acceptable, number to help you pick a case. We used to do 6 pieces of the prostate, but we missed a lot of the cancers. And then if you do more than 12, then we have a bit more complications, like blood in the urine, blood in the stools, or infection. So 12 pretty much answers the question for us, for the majority of people. Now, for the receptors, there are a lot of studies going on. As Professor Redus Henry said, normally there's a lot of markers looking at the basics biology. You know, we have got the temperance gene and other things, trying to use them to answer the question about aggressiveness and the combination of them. They are still ongoing. But we have what we call nomograms. The nomograms try to find out whether this cancer is dangerous. And it takes into consideration the person's age, the Gleason score we talk about, the size of the prostate, what we call the T-score, sometimes the number of cause in which there's a cancer, as Henry said. Is it 2 out of 12? Is it 9 out of 12? We put all of them into this food basket, and by computer calculations, consider this patient's chances of, let's say, dying from prostate cancer is 80% or is 90% in 10 years or in 5 years. So this is what we do. So we use the nomograms. That is much more personified. Otherwise, then the 3 criteria we used, the PSA more than 10, the Gleason score more than 6, and the Digital Rectal Examination more than what we call T2C is enough for us to see whether your cancer is bad or not. Generally, prostate cancer is a very slow cancer. I always say it's a gentleman. You know, it's not like the breast that within 6 months or 8 months is taking you away. Prostate cancer can be with you for 5, 6, 7 years. You know, start with you go for 1 term in parliament, by the 2nd term you are gone, you know. So it takes you slowly, but I'm sure, and that is it. So a year may not make much difference. For some cancers, 3 months is a lot of difference, like breast cancer, like bladder cancer, like kidney cancer. But prostate cancer, if not even 2 years, doesn't make much difference at all. But of course, if the Gleasons and the parameters are bad, then that can be bad. So a year may not make much difference depending on what our initial, you know, findings are. So that's what I'll say for now.
I'll just add a little to what Matthew said. So just putting the first part of what Matthew said, there are no commercially available markers for prostate cancer now. The person who asked the question was wondering whether there's ER/PR HER2/neu for breast. There's nothing like that now. There are a lot of things being developed, being researched to see whether there will be some markers that will help. What is available in the US now, apart from what Matthew said? So Matthew talked about the fact that we use the PSA, okay, the first thing, we use the Gleason score, and we use the clinical examination and the imaging to see whether the tumor is confined to the gland or beyond, and then the nomograms. But in the US now, there are now these genetic tests. You know, one is the commonest on the market is called Polaris, but there are others. It's similar to in the US, we have Oncotype DS for breast. Okay, so for breast, apart from ER/PR HER2/neu, which are important prognostic markers, every breast cancer has to have those markers. I mean, it's criminal to diagnose a breast cancer and not have the ER/PR HER2/neu status. In the US now, Oncotype DS has now been available for like 15 to 20 years now. So it's multiple genetic mutations that are analyzed in the tumor, and then based on historical data, we're able to predict the risk for recurrence. So for example, in the case of the breast, it can predict the risk for recurrence in that breast or the contralateral breast, the risk for metastasis. So the Polaris is able to suggest, okay, what the risk will be. So for example, in the US, if there's somebody who has a low PSA, has 3+3, which is 6, all imaging shows that it's only confined to the prostate. And there's a discussion with the urologist about active surveillance. The urologist is going to do Polaris, and the Polaris will come out with a score, and that will suggest the risk of progression from the less aggressive, we are talking, to intermediate or to the high grade. So I don't think Polaris or any of those molecular markers are available in Ghana, but we don't have any equivalent of ER/PR HER2/neu for prostate. No, we don't.
Okay, I think we can move on to another question. And this is, from what we are saying right now, does it mean that, you know, for every, I'm talking about Black people, I'm taking whites out of this. For every African person, you should do routine screening for prostate cancer. If in that case, for all of you, what do you normally use to screen? How do you do it? Do you use PSA? Do you do digital rectal exam? Which one would you do first?
Koba, Matthew, I mean.
Yeah, Koba or Matthew.
Koba or Matthew. I mean, I would say that, like, from the discussion we have, if you are an African and you are above age 45, I mean, in the US, if you go and see your primary care, beyond age 45, African American, you likely your primary care will suggest my PCP, I mean, from age 45. And are you allowed, insurance pays for a PSA screening, I think, every 2 years. You can choose to do it every year, even if it's low. And in between those years after 45, I think you have to pay it. So the question we are asking is that, Koba, if now you see anybody in your clinic, let me not use 45, let's say 50, do you recommend to every 50-year-old Ghanaian, if they come with you just annual screening, they don't have any symptoms, do you strongly suggest to them that you want to do the PSA test? How do you handle, and you want to do a digital rectal examination? How do you?
Okay, so yeah, thanks for that. So, I mean, in the past, and for this is what we've been doing, like I said earlier on, and I think what we've discussed so far sort of places more emphasis on it. But at 50, everyone gets a PSA, symptom or no symptom. If you have a family history, is it okay? Can you? If you have a family history, we recommend, or we I always advise that you do it between 40 and 45 years. So I have quite a number of clients doing their PSA screening between 40 and 45. Maybe 40 may be a bit too early, but Matthew, what would you say to that? But when I have people who have a very strong family history, I normally would do it by 40. If you have just one relative line, I'll probably do it at 45. But from today, I think it's quite clear that at 50, everyone should be doing it routinely. And that's one thing I think we are all taking from here. So when you are doing your colonoscopy, you are also adding your PSA. Do I do a lot of digital rectal exams with the non-medics is putting your, sticking my finger into your anus? I don't do a lot of that in my consulting room. Rarely. I would often do an ultrasound or request for an ultrasound. And then if there is a high risk or incident, there's the likelihood that there could be something cancerous or the sizes, are very huge, I'm likely to refer to a urologist. I normally don't do the DREs, but definitely the PSA you get.
Okay, thank you very much. I think
it's blood work. So if there are any, so it's just blood work. So it will be part of your labs that we are taking.
Yeah. So I think Koba has put it right. So the first probably point we want to make is that the treatment for prostate cancer has a lot of effects on the male urinary system and sexuality, in fact, and fertility. Urine, sexuality, and fertility. So if you catch a 40-year-old who just married a year ago, and do a PSA, his life is going to be miserable. No, so we normally will give you opportunity to finish the family and get settled down a bit, because it's a slow going, cancer. So we allow that room. But of course, I must say that I mean, just this Friday, a patient, 45 years old, and his PSA was 814.
Ooh.
Wow.
45, 814. So we see 840, 45, and we're asking ourselves, probably should have been seen earlier than the 45.
Yes.
Of course, his father died early. He doesn't know what killed the father, but he knows that his father died early. That he is aware of. So that is it. But definitely between 40 and 45 is a lot of discussion. Because if the person is just, like the first case, he's now going to start another family, then managing prostate becomes quite devastating. So otherwise, I think 45, 50 is a good idea. It must be done, so far as I'm concerned. I realized that when I was going through the question, somebody asked about urinating 3 or 4 times in the night. In that part of the world, I've realized that apart from diabetes and hypertension and their medications, which can make people have what they call nocturia, waking up 3 or 4 times at night to pass urine. Another thing, after people have what called water therapy. People drink a lot of water, and that can also be another issue. So If you're urinating 3 times in the night, you're looking at diabetes, you're looking at hypertension, is medications, you're looking at water therapy. Then we can come and look at the prostate probably as the 3rd or 4th line reason. Unless there are other symptoms like you have to push to urinate, the urine is not coming, then the nocturia alone or the urine at night alone, that is not standing alone, then we look at the prostate primarily. But if it's standing alone, prostate is quite a bit lower on the scales.
Let's chip in this
okay.
Let's chip in this in here. And one other thing that I normally see with people urinating a lot at night is just the temperature in the room. You know, so, some people, I think they have very cold rooms with their ACs blasting at 16 degrees Celsius. And once they push it up, it goes, I mean, the number reduces a bit. So it's a combination of probably the water therapy that Matthew is saying and cold temperatures. Yeah.
So there are a few more questions that I want us to answer before we go on. So I think you've answered some of it. So somebody said, you mentioned difficulty passing urine and blood in the urine. And then you also mentioned constipation briefly. So he wants to know kind of a little bit more about difficulty having bowel movement and traces of blood. You know, if you're able to, furthermore, if you're able to explain whether there's any justifiable cause why men might have need to pass urine 4 times. Okay, I think you've answered that part of it. The other one is, what is the extent of involvement of other allied health professions, for example, physiotherapy, in the management of some of the complications in the US? I guess we'll add Ghana to it too. And then next one is, how expensive is treatment for prostate cancer in Ghana? And he thinks that the expense may definitely affect treatment compliance. And then another question, can I just walk into any lab and request a PSA without a physician's request? And the other question has been answered. So yeah, these are the questions.
Okay, so I think the question about whether there are other specialists involved in the management. Probably I'll just take opportunity to talk about how we treat the local prostate cancer. That's what we are talking about. A cancer that, because you went for screening, it has been found. And in Ghana here, most laboratories will do the PSA for you. Once you're a man or you approach, they'll do it for you without necessarily asking for a doctor's request. So it's being done routine in most of the labs now. So when we make a diagnosis of prostate cancer, we have discussed just watching you or active surveillance to intervene later should the parameters change. We are finished with that. But if ab initio, the parameters are not favorable, the PSA is more than 10, let's say 15, 18, the Gleason score is more than 6, 7, 8, 9, 10, or the rectal examination says that the whole prostate is almost occupied by the cancer. We can decide to do surgery, what we call the radical prostatectomy, where we remove the whole prostate with the cancer, like they would do for a breast or for a stomach or for a colon, so that we take the cancer away with the surrounding, what we call lymph nodes, or where they are likely to seed, and that is a cure. The next option is using X-rays or radiation. So we shine radiation like a torch on the prostate to kill the cancer cells. It's equally effective. We can also do what we call brachytherapy, whereby we put the X-rays, the radiation, but as little seeds into the prostate. And when we do that, the radiation will virtually, kill all the cancer cells. Maybe I can share my screen if so we will allow me.
Yeah, no, yeah, I'll stop sharing and share your.
So I can just get.
You can share now.
Thank you. Okay, so good. So this is the radical prostatectomy, where we do a surgery. We cut the lower part, of the prostate, so that we can be able to, so we make a cut in the prostate area, and then we remove the prostate with the cancer and everything. There are a few other things that are not here, but they are lymph nodes and things. And this is a cure. So that's one way of dealing with it. I'm showing this slide because this is where the physiotherapy comes in very handy. Because after this surgery, what happens is that a few people may have difficulty passing urine, what we call leakage of urine, and that needs to be dealt with. Now, why is this so? I'll just jump to this diagram. Okay. Okay. So what is happening is that there's an area here, this muscle here, that controls how we are able to urinate. So there's this muscle here. But when we go and remove this surgery, sometimes we damage this muscle. So your ability to control urine goes down, and so you may leak urine. So the physiotherapists work by exercising these muscles in the lower abdomen, what they call the Kegel exercises and other terms, to strengthen it. When you do that, then we can get the urine control coming quickly. So that's where the physiotherapists come in very handy for us. So we mentioned the radiation that can be done. So this is the brachytherapy. So for the brachytherapy, we put some little seeds into the prostate. And once you put the little seeds into the prostate, as you move around, the radiation kills these cancer cells. And so we get some relief. The only challenge with the brachytherapy is that it's effective if the prostate is small. It should be less than 50 grams. And then, of course, it must be 6 or less Gleason score. So it's normally good for the favorable ones. And that is it. But if that is not going to work, then we can do the radiation therapy where we put some radiation on it like a torch. And when you combine these things, they can be able to kill the cancer cells. There are other experimental things like what you call the ultrasound, the HIFO. It's found not to be too effective. So most places it's considered experimental. A few Ghanaians who have had it done, it's not in the country, but they got it done in Germany. Most of I've got the 2 people who have died when they came back because they won't let you touch them, and yet the cancer killed them because it wasn't very effective. So most places experimental. Then you can also use ice, what we call cryotherapy. Again, that has also not proved to be very, very effective. So that is also experimental. The cryotherapy has come very handy now. Sometimes when you go and do radiation, a few years, you realize that the cancer is coming back. And they realize that if you go and do a cryotherapy on such a cancer which is coming back after radiation, they tend to do very well. We normally don't want to go do surgery after the radiation because the complications are much more. The urine leakage is more, erection problems are more, and sometimes we get damage to the rectum, what we call rectal fistula. And so we normally wouldn't want to do that. So the cryotherapy has come to be very, very handy after failure, after the radiation therapy. So these are the treatment options that we have. But normally the physiotherapists are very, very helpful for us when it comes to the radical prostatectomy, where the incidence of urine leakage is high, to strengthen the pelvic muscles so that we can get the urine control.
Dr. Jonathan Lai, would you be able to talk about, do you know anything about robotic prostatectomy, and do you know if there are any benefits to that beyond radical?
So, so robotic surgery, I should say, is just a tool in how you do the surgery. So using the robot is, using a machine that helps you to do the surgery without making big incisions. It facilitates doing the surgery. Now, that being said, for a number of, so again, with robotic surgery, we can do surgery, remove the prostate, do exactly the same thing that Matthew was showing, and the patient can go home in 2 days. Even in some places, they go home after a day stay in the hospital, as opposed to staying in the hospital for a week or 10 days. So definitely it has its benefits and it has its uses. However, there is no evidence to show that doing it with a robot is better from a cancer standpoint than doing it with just opening. One of the areas where it may be helpful is that because of when you use the robot, you have 3D vision, you have magnification, so you can see better. You can do a more precise lymph node dissection, and then also, depending on the skill of the surgeon, you can avoid the nerves that Matthew was talking about that affect erection and the sphincter muscle of the bladder neck, more. So from a cancer standpoint, there is no evidence that using the robot is better than doing it open, but it has some benefits in terms of early recovery and things like that. So there's a question from Facebook, Matthew, if you can answer that. It says, is BPH related to prostate cancer? So can you just say what BPH is? And the question is it related to prostate cancer?
Okay, good. So I think the question on robot, I think Dr. Laye, who is much familiar, has seen that. Of course, we have got interactions on that as well. And as he said, I mean, there isn't much advantage, except the early recoveries, as he said, that people can do it, and by the third day they are home, compared with us keeping you sometimes for about a week before you go home. But so far as the outcomes are concerned, not much different. Even though, of course, as time goes on, years of experience, people realize that there's a slight advantage in terms of some of the complications, as he has said. But it comes with money and cost. But we are looking forward to doing that, bringing one robot to Accra one of these days. Good. So now the question, the person, asked, hey, have I made that question? I think, can you take the question again, please?
What is BPH and is it related to cancer?
Okay. So BPH is benign prostate hyperplasia. Now, when you take the prostate, it's like a palm kernel. There's an inner, fruit, and then the hard core. So normally, prostate cancer comes from a prostate hard core, what you call the peripheral zone. So that's where the cancers come from. While the BPH comes from the inner part, you call the transition zone, like the foot area. That's where the BPH comes from. Now, the risk factor for developing both of them are the same in terms of it runs in family, smoking, obese, lack of exercise, too much testosterone, being an African. So they share the same risk factors, but they behave differently. While prostate cancer kills you by spreading and going everywhere in the body and chewing you up, BPH causes problems by affecting the urine flow, blocking the urine flow, and sometimes killing you because it damages the kidney and you need a transplant or something. Otherwise, it kills you. So there are two different things. When we did a study in Ghana, we realized that about 18% of Ghanaians will have a BPH between 50 and 74 years, symptomatic. So almost 1 in 5, 1 in 6 may develop a BPH. While prostate cancer is about 1, in 7 or 1 in 10. So many more people have BPH than the prostate cancer, but the risk factors are the same. But BPH doesn't kill you at all. And because BPH is coming from transition zone, we don't think that BPH metamorphosis will become a prostate cancer. No. So BPH has its own line and prostate cancer has its own line. The only thing is that there are a few prostate cancers that originate from the foot area where the BPH arises. But BPH and CA prostate are in their own lines. But you can have somebody who has both BPH and CA prostate in the same person. So they can't urinate because of BPH, but prostate cancer is also eating its way across. So that is it. When I was talking about PSA, I explained that you find people whose PSA is 8 and they go and then it is not a cancer. They are BPHs. So it is the PSA is coming from the big inner core that is driving the PSA, but it's not a cancer. So there are two different entities, two different clinical scenarios, but the outcomes are different. But again, they can kill you. This one, because of the complications from renal damage, infection, stone, and bleeding. While this one, the cancer itself will eat its way and cause your demise.
So there's I think there was a question that you didn't answer. The question was about the cost of treatment of prostate cancer. So can you address that? And then also there are two other questions. One is that, is there a link between prostate cancer and erectile dysfunction? And the other one is that there's an assertion that frequent sex reduces the onset of prostate cancer. Is that true?
Okay, good. So let's start from the back. Erectile dysfunction, ejaculation. We know that the prostate is an integral part of our, reproductive system. It produces secretions, including the PSA, which goes into the ejaculate and provides the energy that is needed for the sperms to move. So it is an integral part of it. Good. Now, what we know is that the nerves for erection, what we call the cavernosal nerves, run close to the prostate. So for erection, you need the blood to flow to the penis, and you need the nerves to fire the whole system. Now the nerves are close by the prostate. And because prostate cancer can infiltrate or can eat its way outside the prostate, it can eat its way and destroy these nerve connections, like the electrical wires, such that then erections goes away. So if somebody has got a prostate cancer and he has got erectile dysfunction, there's likely to be a cancer that we are not going to watch because it may have moved outside it and it's eating its way there. So that is one way. Another connection between prostate cancer and erectile dysfunction is the interventions that we do. If we decide to do the radical prostatectomy, the nerves are close by. We try to use magnification to see the nerves and push them aside. But it's not always that we succeed. Sometimes we get them caught up in the whole process. Sometimes we use a bit of what we call diathermy and heat to dissect our way, whether robotic or open. And this can inadvertently bend the nerves and they end up with erectile dysfunction. So our treatment can cause that. The radiation itself is also another heat energy. And when you put radiation, the whether brachytherapy or the touch, that can also affect the nerves that are close by. That's why we say that normally we don't want to get a young person and start catching him and looking at the prostate because of all of this, risk. Of course, we are perfecting the art. So most of these risks are low, 10%, 20% and low. But again, 1 out of 100 is even an issue for a younger person. Now, he asked whether ejaculation is protective. It looks good. It looks true. There's one study that have shown that multiple ejaculations can protect against prostate cancer. And there are things that put in place. Let me put it this way. We know that early vasectomy can predispose somebody to prostate cancer. So vasectomy in the 20s, vasectomy must be done in the late 30s, 40s. The reason is that while the sperms are not being transported and they are within the testis area, they are resorbed and we produce what we call oxygen-free radicals and other radicals. And this causes changes in the genes and that can promote prostate cancer. So if you block your sperms from flowing and the body has to resolve it and break it down, then you produce these free radicals that will promote prostate cancer. So if you look at ejaculation and this issue about vasectomy leading to increased prostate cancer after every decade, then there is a connection that maybe free radicals from this metabolism can affect it. Now, interesting about, I think around December, I saw a gentleman, in fact, he was about 72 years. And there were two of them from the northern part of Ghana. They call them now in two different skins. So he comes to me with symptoms that finally was a BPH. He had one wife and he was having difficulty passing urine. And his other brother, who was now in another skin, had 23 wives. And he was urinating freely without any difficulty. So he asked me why that he has got one wife and he has got this difficulty, and his brother who has got 23 wives has no difficulty. So after we have discussed this issue, so I asked how his brother was doing. He said, anyway, my brother died last year. And I said, how killed him? He said, heart attack. I said, the women have killed him.
Something will kill a man. Something will kill a man.
Something will kill a man.
The cost of treatment. So for radical prostatectomy, for those who are using insurance, private insurance, they have been able to negotiate quite well. So the radical prostatectomy costs between about 8,000, says 8,000 in Kolebu, generally around 20,000 Ghana cedis, 25,000 Ghana cedis with a private insurance system. And it can be as high as $5,000, $8,000. Sometimes people actually request some specialists to come from abroad to come and do it for them. Ghanaians, in the diaspora who come and do this surgery. Then it goes higher up to 8,000, 10,000 because they are paying for and everything else. But they are on personal request and based on volumes of that. We have got a few Ghanaians who do a lot of volumes because of where they practice. So that is how to rate. So it ranges from about 1,000 Ghana cedis or $1,000 to about $10,000 depending on the facility and the expertise that you are trying to have. But averagely, about $2,500 is enough to get you a radical prostatectomy. The radiation therapy is about $1,200. So it also ranges about $1,500 to about $8,000, depending on the facility that they are offering you, and depends on whether it is, the normal radiation therapy or highest ones like the conformal and image intensifier, then it becomes more expensive. Brachytherapy is going for about 9,000 euros because we have to get the seeds from Germany and Turkey with all the UN monitoring and everything. So it's quite expensive to move the seeds around and makes it quite expensive. So this is how it is. Of course, sometimes we choose to give hormones. And for people who are elderly, 80 years and above, we can use hormones, what we call intermittent androgen, and that is cheaper. We give 4 injections, which may end up to about 5,000 or 4,000 Ghana cedis. And I've got a few people who are on the intermittent hormones for the past 5 years, 6 years, and they are doing fine because they are in the 80s. And as you say, something will kill you anyway, so we move on. So that is how we manage it.
Matthew, whilst you're on, I have 2 quick questions for you.
Thank you.
One, when it comes to brachytherapy, right? You are talking seeds. Are they radioactive material? Can you explain that? And then for how long would they emit whilst they are in the prostate? And for the period where they emit rays, is there other people in the family or at home? Is there any risk to them at all?
Good.
And
yes. Oh, go ahead.
2 is, we've spoken about the fact that now we're going to screen more aggressively.
That's
now,
right.
if I see someone at 70 years has never had prostate screening done, would you recommend that I start chasing him at that point, or it would depend on his general health? At what point wouldn't it be necessary to screen for prostate cancer? If the person hasn't done any before.
Yeah, I think we start from that point. So in most jurisdictions, they will say that above 75 years, probably there is no need. The reason is on the fact that most people will survive the treatment of localized prostate cancer, whether you treat or you don't treat them, for about 8-10 years. So if your life expectancy is about 64 or 62, then most people will not survive that. So if the person is 75, living to 85 is pretty unlikely. In fact, most part of the world shows that for you to live from 70 to 80 years, only 50% of the world population survives 70 to 80 years. So if you are going to add 10%, then if they are 70, 50% chance that you will succeed. If the person is 75, 25%, 20% is not worth it. So most jurisdictions will not say that. Once in a while, we get 80, 82 who come in bad disease. But I mean, we'll manage 2-3 years, we'll wear white and come for the funeral. I mean, something must kill a man. So 75 is fair. Below 75, probably not. But I've got some people who are so scared that even when they are 82, they still want the PS. And as I said, it's a shared decision. We still offer it to them. Brachytherapy, the seeds contain the radioactive agent. Other is iodinated and other compounds. And when you put it in there, it emits the radiation for about 3 months. So for the 3 months, we say don't put a baby on your lap, avoid sexual contact. We try and keep things away from your perineum, that's around the anus area and around the lower abdomen as much as possible. And in fact, after the brachytherapy, you still get pain or urination, some discomfort there because actually heat that is there, just that it's releasing slowly. So people feel very uncomfortable down there, but it's self-limiting. By 3 months, all of them has gone away. So yes, that is it. And even if you decide to have sex, we don't want you to produce a sperm for a baby. So we advise that even they have sex, they should use a condom so that they don't impregnate anybody. Because if you go and impregnate a baby, you may end up with abnormalities because the radiation may have destroyed the genetics of the sperm. So you use condom, no baby on your laps as much as possible if you can avoid bringing things closer to you. But within 3 months, pretty safe after that. Yeah.
Thank you.
Thank you very much.
Oh, so you muted yourself.
We're going to move a little bit to issues that a lot of men worry about a lot. And there is data that suggests that as we all age, the risk of erectile dysfunction goes up. A lot of data suggests that the rates in men who are above 40 years, about 30%. how do you guys, anybody can answer, how do you manage your older men with erectile dysfunction? How do you handle them? You know, what are some of the treatment modalities that you use, and how are you going to risk stratify them to decide which type of treatment they would benefit from? And then if you decide not to treat, how do you advise them? And it goes to anybody can answer this question. Koba, Matthew, Edubi.
Okay, so I'll just put in the landmarks. Okay, good. It's interesting that, you know, when you talk about sex after 50, my observation is that there are some who want to have sex because for the pleasure. There are some who want to have sex because they must keep their women happy and keep the home going. They are so concerned about their businesses and their buildings and their things that sex is not a matter at all, just to keep the home going. And the others want to be assured that the thing can work. So there's no partner at all. Either they are widowed or the partner has traveled outside to look after their grandchild or something. But they always come to make sure that the system is intact. So the first thing is to know what are the person's aspirations. It makes a lot of difference, because some of the aspirations, by just interviewing, they realize that everything is intact, that there's no cause, for alarm. So for the average 50-year-old, we are looking for pleasure and we want to make sure that our marriage keeps safe. Good. So what are some of the things that will affect a man who have poor erections at 50? The average elderly men, they are 80 years, they are still firing. So it's their lifestyle. I always see Sowi on his bike and I'm saying that Sowi is doing a good job. You know, it's one of the things you can do, exercise. Okay. Because blood must flow around. And if the blood vessels are blocked by excess fat, the cholesterol and the lipids, their erections becomes very poor. It normally shows by having, if those who go on second or third rounds, after first round, sometimes it takes 2 weeks before you can do another one. Because once blood flows, it takes a long time for it to come back. But if you're exercising, then it keeps the blood flowing very well. The brain system is important because the desire for sex itself is from the limbic system, the hippocampus and every place like that. There are some people who do not think about sex, and that is the truth about it. Other things have occupied the whole of their thinking faculties. So the brain is important. Again, the exercise is important. Testosterone levels are important to keep the brain having desire for sex. So these are the systems. So I always say that erection in 50-year-old is important. And most research have shown that erections correlates with life expectancy. If your erections are poor at 50, the chances that you live to 60 is bad. It's not likely. And it's not surprising, because when you look at the causes, I mean, we've got the psychogenic causes where are related to the psyche, and organic causes. Uncontrolled hypertension, uncontrolled diabetes, cardiac problems, smoking, excess alcohol. All of these can lead to erectile dysfunction, low testosterone, high, thyroid problems. So the organic causes are life-threatening. So if you're 50-year-old and erections are getting poor, then you must see your general practitioner, you must see the specialists, like the COBA and other people, to set you up. But before you come to a urologist, you must see them and let them check your blood pressure, let them check your sugar and everything else. Those who walk to us as the first port of call, you come and do their random blood sugar, and it's 23, is off the scale. So that is the first point of call. So for those on this platform, if your erections are poor, please approach your physician and let them assess you completely before you come to us. There are a few people who have got prostate problems, who have got rectal cancers and other things which are lower down there, and so affecting the nerves and affecting the blood vessels. They are quite obvious. They have other complaints, other symptoms that makes you know that this is the reason. But the average 50-year-old man with erectile dysfunction has everything to do with their general medical conditions and the medications that they are on. When they come to us, we'll ask you to exercise, and that makes a lot of difference. And then the diet. The truth is that the aphrodisiacs we have, they work. The atadri, the Quaker oats, the zincovies, and drinking oil, they work. The last time I learned Kenya the atadri has become extinct in Nairobi. and there's a high container full of Atadwe from Ghana to Nairobi. It's a market now. So those who want to invest, it's a huge market out there, for Atadwe, people, they do it into milk. So now they export it and they are processed into, the milk, the Atadwe milk, and it's being exported all over the place. And it's because of aphrodisiac. So that's what I'll say for now. When it comes to treatment, we'll discuss it. But I'll say that probably the general checkups is important. Erection going down is an indication that there's something wrong with the body. And if you don't look at it, you'll be dead pretty soon. Thank you for now.
There is a question in the chat. Say we are seeing an increase in testosterone use here in the US, even in patients who do not have hypogonadism. How does this impact BPH and prostate cancer?
Okay, so for us men, testosterone is a very important hormone that keeps us active. The way we think, to do mathematics, to remember things depends on testosterone. Our muscle bulk, our blood levels depends on testosterone. Be able to have good erections, ejaculation, all of them depends on testosterone. So testosterone is very important for our system. We also know that as we get older, our testosterone level goes down. It's estimated that we lose testosterone about, 1% or 1 gram of it almost every, or less 1% of it almost every year after 30 years. And it shows in that most of us are losing our hairs and becoming bald and everything because testosterone is going down. So as you get older, testosterone will go down. But for you to make the most of the testosterone you have, exercise has been found to be most useful. Because when you are a bit obese, the peripheral fats are able to break down the testosterone into estrogens, which will then fight the already low testosterone. And so all these benefits of testosterone, then we tend to lose it. You feel tired, you can't think properly, you feel depressed, and that is it. So the solution for that is that the exercise and watch your fat intake and then watch your obesity. If you work on that, that should be able to help. If that doesn't work, then we can go on the testosterone. When you take testosterone from outside, there's a first precaution. The first precaution is that we must make sure that you don't have a prostate cancer. So if you are 45, 50 years and you want to use testosterone, we must exclude prostate cancer. And that comes with the PSA, with the rectal examination, and a biopsy if there's a need for that. Because if you put testosterone into a prostate cancer, it's like pouring petrol on fire. The cancer will run away and kill you quickly. So in most places, for you to have a prostate cancer testosterone replacement, you have to exclude prostate cancer. Another thing about exogenous testosterone is that when you put it in, it goes and blocks the natural testosterone that is produced from the testes. So the most potent testosterone is produced from the testes, what we call the dihydrotestosterone. But when you put in exogenous testosterone, then this natural dihydrotestosterone is not produced. So what you see is that your testes become smaller, atrophic. You become azoospermic. Your semen will not contain any sperms at all. So you have big muscle mass, you are thinking straight, you can exercise, but the testis disappears, sperms disappears. And this is the challenge that we have with exogenous testosterone. So those who use it early for bodybuilding when they are 18, 19, 20, after a few years, they'll be fighting for fertility issues because when you do their sperm counts, it's either severe oligospermia or azoospermia at all. So that is how, but if we check that the testosterone is really low, which most of the labs here can do, especially the recognized ones, then there may be replacement. But for an African at 50 years, you want to take testosterone, prostate cancer must be excluded. Otherwise, even if you have got a prostate cancer, which is good, testosterone will turn it into a bad prostate cancer for you. Good.
So you're muted.
This question is a question that sometimes comes up a lot, and this is premature ejaculation. It's not a common complaint that men share, and even in my practice, I've heard maybe about 2 men say it, and one of them his wife brought him. And do you have any advice for doctors and their patients on how to handle this difficult problem? And this Koba or Matthew or Jonah, anybody can take this question. How do you handle premature ejaculation? If anybody has.
Okay, so maybe again, maybe I'll just set the ground rules. Intravaginally, the average man lasts about 6 minutes. Previous used to be 2 minutes, and the women argued and fought it. So WHO has moved it to 6 minutes. So now average is 6 minutes. Now we know that the prepuce, the tissue we take as circumcision, contains a lot of nerves. So those who are not circumcised have a very high, stimulation compared with those who are circumcised. So anybody who is not circumcised, to intravaginally make 6 minutes is a lot of effort and a lot of time to be able to achieve that. But for those who are circumcised, they can go 6 minutes, they can go 20 minutes, because the prepuce takes away, the circumcision takes away a bit of the nervous stimulation. And so most premature ejaculations, you find it more in people who are uncircumcised than those who are circumcised. So if you find somebody who is uncircumcised and the complaints are premature ejaculation, in other words, intravaginally lasts less than 6 minutes, sometimes circumcision can be the solution to it. Now, we know that there are some parts of the brain that can suppress ejaculation, normally handled by dopamine. So you realize that now people are using what they call a tramadol and trauma, and also the antidepressant, the serotonin, selective serotonin inhibitors, because they act on the brain side, a place that suppresses ejaculation, then that can also help delay the time in which one will ejaculate. So we tend to treat them using this serotonin reuptake inhibitors and then tramadol, and that works very well. In between our counseling on what are the issues, you understand? I mean, sometimes some people spend the whole time foreplay. By the time they get to intravaginally, it is over. So we advise about that. We also advise about what they call the in-out or squeeze technique. If you think you are getting there, you can come out, and the whole system will reset itself again. They can go again. No matter when you go back, you can actually go longer than you did before. Of course, not all the women like that. Sometimes you see you've left them midway, and if they don't slap you, that's good for you. You understand? But you can do that. You can also use condom, because what the condom does is that it's preventing the nervous contact. So we are covering the glans penis, which has got the nerves. So once we do that, then there's no contact. So the ability to get stimulation then goes down. So that can be. So for instance, the first round, you can use a condom. After that, after first ejaculation, the next ejaculation naturally is latent. It delays. In fact, by the third time, you are struggling to get you to come out. You can be in and out, and they suck you because you are keeping too long. So the first one, you can use a condom, and then you can be able to, that. So I always tell people that, so that you apologize before you start, and then you make room for the second and the third attempt. So that's how we handle it. People have used topical antiseptics, so they call it local anesthetics. So the lignocaine and things. The disadvantage is that it numbs the woman, so they don't enjoy it. So then, if I don't throw it away or hide it somewhere, you won't find it again. It's not helpful. So that is how we handle it. That's it. Now, for some people, it is serious. One gentleman told me that by the time the wife undresses, he's already ejaculated, and it can be that bad. For them, sometimes we really go and denervate the glands. Some of them are already circumcised already. So we go and denervate the glands. So we make around the circumcision incision, around where we made the circumcision, and identify every other nerve using the magnification and burn it off or cut it. So virtually like I don't know what is it, hemmings, very good, like a hemming. We cut every other nerve so we can be able to denervate it at all. And in the Far East, where they don't do circumcision, this is one of the things they are doing to be able to help deal with those who have got severe cases. I've not had to do that for anybody here. Most of the time, the tramadol and then the serotonin reuptake inhibitors, which we tend to prefer because tramadol is additive, tends to work well. So that is it. But by 50 years, you must have mastered the game. If 50 years, you say a premature ejaculation, there's something wrong with you. You know, you see it in the younger people, 18, 24, but 50 years. You know, so we by this, Koba should be master of the game by now. You shouldn't be having premature ejaculation.
I would like to add that there is some research that suggests that there are some genetic polymorphism that actually predispose to premature ejaculation, and it's been found in the Vikings. And I think, you know, the Vikings conquered a lot of places and most probably helped them spread their seed. If you're going to be out in and out in a few minutes in the war zone, it could help you. But there are a couple of questions in the chat. Jonah, do you want to go through them?
Okay, yeah, so one of the questions was that which drugs affect erection? Another question is there evidence for sound wave therapy over the penis for reopening the blood vessels and to cause new blood vessel formation? And then for the tiger nuts, a tawdry thing, is there any scientific evidence for it? And then the last one is baldness due to low testosterone?
Oh, well, I think I'm here. Good, yeah. So baldness can be due to low testosterone. Even though, of course, they are genetic. I think the genetic ones is quite more common in rats in the family. But low testosterone can be not baldness per se, but receding of the hairline can be due to testosterone. Now, for the scientific basis of the tawdry and all those things, zinc as a metal or a trace element is very, very important in male issues, testosterone production, semen ejaculation, movement, and everything else. So anything that contains zinc is very helpful. So that's why the tawdry is helpful. Quaker oats is very, very good. Sometimes we just put zincovite or combinations of all of these things. You find zinc in them. Anything they are giving you to make supplementation, you find zinc in it. So zinc is the main thing that drives most of these natural things, as well as the other supplements that we give. Good. So now for erectile function, we said that one of the major issues is blood flow. So when we decide to treat erectile dysfunction, we have what we call 3 lines. Probably I'll say 4 lines. The first line is what we call, counseling and advice. Appreciating your wife better, your wife losing weight or you yourself losing weight, understanding each other, solving conflicts in the family. These are things that can make erections come back when they have disappeared. I met a couple, they stay in the same house, and for 3 years, they have not had any sex at all, and they come and go as if nothing is happening. Finally, there was a conflict. And the conflict, one person is not willing to apologize, you understand, for a conflict. And because of the conflict, they stay in the same room and 3 years, no sexual activity. So those things need to be dealt with for it to happen, what you call the partner-specific or sarcogenic causes. Then when it comes to things that we need medication, we have got the oral therapies. To hear about Viagra and ACE surrogates. We have got tadalafil, vardenafil. In now Ghana, we've got them as Dragon and so many other SP. They are all over there because of generic components. So the oral medications help. They allow blood to flow to the penis and you can achieve erections. Then there are topical ones. They are creams or gels that we can put into the urethra or the beginning of the urinary tube, and those also work. We consider them as first line. The second line is what we call the intracavernosal injections, where we give an injections into the penis, which are the natural chemicals that produces for the erections to happen. We have manufactured them like a vaccine in the laboratory, and we inject them into the penis for the erection. We consider that as second line, and they're also available across the globe, so we can do that. Just that it's like an insulin syringe. So while somebody is giving themselves insulin to stay alive diabetes, you just give that into your penis and you have your erection. And it works pretty well. So that is second line. The third line is what we call revascularization. This is where you have done investigations and you have established that a particular vessel is blocked, whether we call the iliac vessels or cavernosal vessels, something is blocked. Then you can go and repair that vessel. Either you do surgery to reconstruct it, or you put tubes through the vessels into the area and use balloon to open it up, what we call angioplasty, Foley angioplasty and other methods or you use the ultrasound and other things just to shake off, whatever plaques or cholesterol there, just to create the chances. So those methods are the third line. Their sources are not too clear-cut. Most people consider them as experimental because you must be able to define exactly where the problem is. But most of the causes of these blood vessel problems are general. They are diabetes, hypertension, aging. And so multiple vessels are not working. So if you go and open only one, distal down there's another vessel which is not patent enough for the blood to flow. But the ultrasound, the revascularization, and all the things, the angiography and the arteriography and everything else are the third line. And most of them, they are desperate situations. And the outcomes probably 15-20%, but sometimes desperate situations, desperate measures. Of course, we can solve the problem by putting an implant into the penis. So we make an incision to the penis, call out the bad tissues from the penis, and put a rod inside it. And the rod is like a microphone. When you are ready, you just jack it up. When you are done, you just pack it there. Of course, that is a permanent solution, because when you do that, then you don't have any other option of other things. But the third line means that things are very desperate. And most of the time, when you do that, it works, but then we get into difficulties. But sometimes that is the only option that we have.
Thank you very much, Dr. Che. Today I learned something. There's a bypass for the penis. So this is something that, I would have to keep in my back pocket, that whenever things don't work, we can always get a bypass, not the heart bypass, but a penis bypass. Good.
So there's one last question here. Says, is ginger and bitter cola, can ginger and bitter cola not improve erection and libido?
It's a difficult question. Let me put it this way. The psychotropic drugs, let's put it this way, the marijuana, in low doses increases libido because they all act in the the limbic system. So marijuana is a high, can cause a lot of increase in libido. So most of these things that stimulates the system, ginger and everything else, coffee, things that makes you not dull and active, in the short run can be helpful. But when you take more, then they become counterproductive. So I have to check. I don't know of any particular element in cola or ginger that may help it. But if you can keep awake, you are likely to do this business. You sleep on it. That's what I'll say about that. But I'll do a check on that. But anything that keeps you awake, a little bit of wine, a little bit of beer, anything that keeps you a little bit of smoking, anything that keeps you a bit on a higher state, it's likely make you enhance the performance. But when you go overboard, then you get depressed and the whole system collapses. Because in the long term, they end up with these vascular problems and then the whole thing goes down completely and doesn't want to come back.
Thank you. Thank you very much. Unless there are any more questions, and I think we should.
That's one.
I think
that's one. That's one last question. Can you say something about priapism? Matthew, can you talk about priapism? What is it, and what causes it, and how is it treated?
So, what do you mean by priapism? It's a form of an erection, but we call it a useless erection. Erection must be purposeful. You got your wife, you got a nice lady, so you got an erection, and it's for a purpose. But if you get an erection that is purposeless, they call it priapism. And normally, erections that are purposeless, they will last for 30 minutes, 15 minutes. You are driving by the road, you spot somebody who resembles your wife, you may get an erection. You understand? That shouldn't last 30 minutes. By the time the car passes, it should last. If a purposeless erection lasts for more than 4 hours, they start giving you pain. And that's what you mean by priapism, because then the blood in the penis may have been used up. And once it gets used up, it starts giving you pain and destruction of the destruction of the penis. Or you have got an erection, normal erection after ejaculation, the penis must become flaccid because sympathetics are stimulated and so it becomes flaccid. But if after ejaculation, you are still having rigid erection, then you are going to move to that phase of 4 hours. And some people can actually go for 2 days and 3 days with the erections on. That's what I mean by priapism. When the oxygen is used up in the penis, then the body decides
to get injured. It's like tying a rope around your finger. It hurts the very soon, it becomes numb, and there's a distraction. So the little vessels in the penis that allow blood to flow are destroyed, and they're replaced by scar tissue or fibrous tissue, and they don't stretch. So pretty soon the penis is there, but it's all fibrous tissue, and they cannot stretch at all. So whatever you have, it stays there. If it is halfway, it stays halfway. You can't get it up, you can't get it down. And that's what we mean by prapism. In that environment, it's common in people with sickle cell disease, especially the SS genotype and the few of the SC. Even though I've seen a few people who are AS, so that is it. In other places, it's related to the aphrodisiacs. I mean, the Viagra, the herbal medications, they can cause you to, the rest to overstay their usefulness, and you get prapism. But it is not a good thing. If your patient stay for more than 4 hours, we need to decompress it and get the blood out. Otherwise, it will destroy the penis. Yeah.
Matthew, I have one. Can I, Matthew, can you hear me?
Yes, I can hear you. Please.
So from what you've said, managing erectile dysfunction, can we safely say that, for everyone listening, that before you try these things, you should get a proper medical checkup to be sure that your erectile dysfunction is not being caused by other things? That should be the norm, right? People shouldn't go buying the medications and the creams and things. That's all. So we've had proper medical checkup.
Yes. I think you are right. Actually, I said one of the things that every man should watch out for at age 50 is your erection. It is a good marker of how you are managing yourself. If you're under stress, if you're overworked, it will first show in your erection. If you are getting hypertension, it will show in your erection. If you are getting that, it will show. So it's a very sensitive, I'll call it antenna, to let you know that you are not doing something right. In the same way, if they give you a medication that is not too good for you, it will show in your erection. Somebody asked whether there are any medication that will occur. In my practice or in experience, every medication can cause it, from malaria treatment to anything else. So you can't put a finger. One medicine for hypertension, which is causing erectile dysfunction in another person, when you give it to them, there's no problem at all. So that is it. But for our purposes, as Koba said, it's for you to know that erection is one of your key antennas. You are overworking. You are not sleeping. We are operating too much. Some of us, we still keep a list of 8 cases a day. When you get to 50, you have to cut it down. You are old, so it's an important thing. And so the first thing is to talk to your physician, is to talk to your general practitioner, let him check around you. Sometimes they will not find anything. They will just advise you to take 1 week off. And 1 week off is enough to get everything back into the system. But if there are other things, prostate cancer, rectal cancer, and other things, as you do the colonoscopies and occult blood and PSA, they will come up. But if there's anything I will advise on this platform, your erection is a good guide of how well you are taking care of yourself. Age 50. It goes down, check yourself. Either your bank account is low, something is not right, check yourself.
Thank you very much, Dr. Chi. And that's a very, very good take-home message. And for now, what I'm going to do is we're going to go around and let all the panelists give us a good take-home message. And Dr. Chi, you are excused if you don't have any more, because that is really, really very key. If there's something wrong with your erection, there is something wrong. Try and figure it out. So, Dr. Koba SL, can you give us a take-home message?
Something everyone can remember. Well, I think at this level, at 50 years, it's important that you do not wait to have symptoms of any illness. See your doctor, get checked out for everything that a man needs to have working correctly. And that starts right through all your organs. So don't wait for symptoms, have your doctor check you out.
Dr. Lai, can you help us with your take home?
I think, we've talked about a lot of things. And again, the important thing is that, as we get older, as a natural cause of growing old, things start going, bad, and sometimes, you are approaching 50 or you are 50 and you think you don't feel it, but the body, has aged. And so it's important that we appreciate the importance of having regular checkups, routine checkups, and making sure that we get our screenings done. So as we talked about, when we talk about screening, we're talking about not having any symptoms, right? So when you have symptoms, we are talking about diagnostics. But when we talk about screening, it's when you don't have any symptoms, that's when we are talking about screening. So, getting checked for your cholesterol levels, getting checked, blood sugar levels, getting checked, we talked about PSA, getting your colonoscopy. Those things are important things that we need to pay attention to, so that if things are beginning to go in the wrong direction, we can get them corrected before they become symptomatic. Now, typically, once they become symptomatic, it's a much bigger issue. And so I think it's important for us to be aware and to also pay attention to, having regular routine checkups, and not only when we are not feeling well.
Dr. Henry Hammer, if you are still with us.
Yeah, so the only thing I'll add, just on top of what just Jonas said, that once we are getting close to 50 or we hit 50, we shouldn't wait. We should have at least go in to see our primary care physician at least once a year. We should make sure we do that. And when we go in the US, and I'm sure in Ghana, most of it, just like Koba said, you need to be screened for your PSA. Close to 50, at 50, definitely your PSA has to be checked. At 50, colonoscopy will be a good thing to get done. And when you go see your primary care annually, you will check your cholesterol, like Jonas said, check your blood sugar. I mean, sometimes they just do a CBC and they'll do a basic metabolic profile. We shouldn't wait to feel that we have any symptoms or not. We at least once a year, we should go see our primary care physician.
Dr. Dubuatin.
And I think I'll share what I've learned from here. I know there's a take home, but I think as we grow older, it's important we take care of our cardiovascular health, and then try and, if we've not done so already, change our lifestyle to be more healthy. I think I probably need to do more exercise. Secondly, I confess I'm a bit of a skeptic, but I think I've become convinced of the much higher risk of prostate cancer in Africans. So I think I'll take that seriously. And lastly, one thing that we probably didn't talk about is as older men, our mental health is also very important. So it's something that we should take a look at. And I think people say keeping in touch with your friends and having these discussions, they do helping to maintain good mental health. So those are the things that I think I need to work on personally. So I've enjoyed this, and I thank all the people for coming around to educate us, and I really appreciate it. Thank you.
And thank you all very much for being able to join us in this panel. And I would just like to say that for me, I'm just going to go back in time. Dr. Lawrence Dubuatin introduced me to something. But one thing about life is that always learn something new. And that is one thing that we should always remember, always learn something new. Almost 30 or more, 40 years ago, he gave me a bootleg account to slip into Tesano Club to start learning how to swim. And I swim thanks to Dr. Dubuatin. There's water and there's nothing. But yeah, that's always, for life, make life interesting. Learn something new. Take time off, once in a while, go somewhere you've not been before. We all aging, it's going to get to the time when some of us are going to be living. Some of our colleagues have already left us. Enjoy what you have, enjoy your family, and then enjoy the money that you're making. Don't just make money, enjoy it. All right. Thank you very much for joining us for this very, very eventful seminar. And we'll try and, from time to time, organize more of these just to teach ourselves and also just as keeping in touch. So thank you very much. Everybody was able to join us. And this is going to be uploaded and put on YouTube. I think Jonah is working on that. So those who were not able to join us can be able to watch and enjoy this very important discussion. Thank you very much for everything.
Thank you. Thank you too.
Thank you.